So hello and welcome to day 3 of the D&I conference. Just out of curiosity, was anyone else singing along with the music as we were about to start? Maybe just me. Anyway, just wanted to welcome you back. Thank you for joining us throughout what's been a great conference so far. And we're lined up for an awesome plenary panel that sits right in front of us. What is innovation for D&I research and practice, and particularly as we see so much change going on all fronts. So excited to see this incredible panel really talk about their experiences and help us think through innovation in all aspects of research and practice. And with that, so excited to have Dr. Reshma Gupta join us as our moderator. She is an assistant professor of gastroenterology and hepatology in the clinical research division at Fred Hutch. She is a gastroenterologist and a clinical researcher who has been focusing on decreasing mortality associated with colorectal cancer with a special focus on medically underserved populations. And for us, a little bit of a ringer in that when we had, some of you may have joined us for our second Implementation Science Consortium in Cancer. And Dr. Osaka was an incredible moderator for a panel that we had where we had different practitioners talking through some of the experience of integrating cancer care during this COVID era. And so we're really happy to be able to rely on her again to help us kick off this wonderful panel. So thank you, Rachel, so much. And please take it away.
Thank you so much, David, and good morning to everyone. It's a true pleasure and honor to join you today, and I'm especially excited about our panelists and what they will have to share with us today on this topic of innovation. So with that, I just want to briefly introduce you to everyone who will be with us today, and then you'll get to know them a little bit more over the course of the morning and have an opportunity to ask questions as well. So first, I have Dr. Aaron Lyon, who is an associate professor in the University of Washington Department of Psychiatry and Behavioral Sciences, and is also co-director of the School Mental Health Assessment Research and Training Center, known as SMART. He is an implementation researcher, and this center really focuses on implementation research and technical assistance center focused on the educational sector service provisions. So if I could go ahead and have all of my panelists for now turn on their cameras so you can see them. They'll go off screen shortly, but you'll get to, again, meet them a little bit later. Next with us is Dr. David Ash, who is an executive director for the Penn Medicine Center for Healthcare Innovation. He is the John Morgan Professor at the Perelman School of Medicine and the Wharton School at the University of Pennsylvania. Third, we have Dr. Reshma Gupta, who is a practicing internist and interim chief of population health and accountable care within the University of California Health System in Sacramento, California. She is also part of the population health leadership team for strategy across all the UC Health campuses. And finally, we have Dr. Vendel Washington, who is the Chief Clinical Officer of the Verily Health Platforms Group and the interim CEO of Unduo. Verily is an alphabet company focused on using technology to better understand health, as well as prevent, detect, and manage disease. And Unduo is a virtual diabetes clinic that provides health plans, providers, and individuals the tools they need to lower A1C. So with that, I'm going to tell you a little bit more about Ryan, who will be our first presenter. So Dr. Lyon, as I mentioned, is the co-director of the SMART Center here at the University of Washington. He also directs the methods core of the UW Alacrity Center and is the associate editor for the Journal of Implementation, Research, and Practice. Dr. Lyon's research focuses on increasing the accessibility, efficiency, and effectiveness of community and school-based behavioral health interventions for children, adolescents, and families. He is particularly interested in the identification and implementation of low-cost, high-yield practices such as the use of measurement-based care to reduce the gap between typical and optimal practice in schools. He's also interested in the development of individual and organization level implementation strategies to promote adaptation and sustainment of evidence-based psychosocial interventions. And finally, his area that he will be talking to us in depth about today is in human-centered design and redesign of psychosocial and digital technologies to improve their implementation, accessibility, and effectiveness. Dr. Lyon is principal investigator on multiple active grants from the National Institutes of Mental Health and the Institute of Education Sciences. So with that, I'm going to turn over my screen to Dr. Lyon for his presentation.
Thank you so much. It's really exciting to be here. I'm going to share my screen quickly because I think I may be the only one among us up today who has slides to present. And the reason I do is because there's a couple of things I want to show you very quickly. And I think that the showing them visually is going to speed things along. So I'm Aaron Lyon, and I'm going to be speaking primarily from the position of being one of the directors of the methods core of the UW Alacrity Center. And I'm going to be talking about the pursuit of innovation through the integration of disciplines with similar goals, but different ways of getting there. And those are really human-centered design and implementation science. Both that are interested in the adoption of innovative practices and innovative products, but that tend to get there through different means. Human-centered design focusing primarily on the thing, to borrow some words from Jeff Curran, the thing that's being implemented and how it can really be aligned with the context. Whereas in implementation science, we tend to focus more on the context and on individuals within it. So I want to jump. And I want to begin by having you all say something with me. And I can't see you and I can't hear you, but I'm going to trust that you're going to say this. The user is not like me. Say it with me in your offices, wherever you are. And the reason I want you to say this is because this is a critical kind of foundational component of human-centered design and how it approaches problems and innovation. And this is because product developers tend to underestimate user diversity in their design processes. But this can be addressed, and we can overcome the sort of tendency to base designs on people similar to ourselves through the explicit identification of end users. And that's a cornerstone of human-centered design. Human-centered design is an approach that grounds the product development process in information about the people and settings that will use that product, and then ensures that that product is going to meet those kinds of specifications. This is a very generic human-centered design model. I didn't invent it, but all of these different kinds of models, there are many out there, in a way kind of akin to all of the implementation science frameworks we have at our disposal. But key aspects of these types of models are to understand the context of use, the users, and to iterate on design solutions in order to meet those needs, to meet those specifications. User identification is a key component of this, and its importance can't be overstated when we're talking about how human-centered design can be brought to bear on some of the problems that many of us are grappling with in implementation science. Identifying the right users is a critical piece of any sort of development and implementation process. And something that I said in a workshop that I helped to co-lead on the first day of this conference really rings true to me related to implementation science and human-centered design. And it's that if you're designing for everyone, you're designing for no one. Within human-centered design, we tend to identify primary users whose needs you are definitely going to meet in any design solution, secondary users whose needs you can meet as long as you don't compromise your ability to meet the needs of primary users, and then non-users or negative users, those who you are explicitly not designing for. We tend to take these human-centered design concepts and help them kind of manifest in our different projects across the Alacrity Center through what we call our Discover, Design, Build, Test framework. This is just a sort of somewhat more specified version of the generic framework I was sharing earlier. But what this really involves is identifying first information about the context and the innovation and redesigning interventions. In our case, this is implementation strategies or psychosocial interventions for behavioral health, iterating on that and ultimately testing it as it relates to implementation and clinical service types of outcomes. One final point that I want to make before I wrap up is that innovation often tends to become synonymous with digitization and with digital technologies. And even though I'm often kind of a self-described tech guy, at the UW Alacrity Center, one of the things we're often focused on is how to make sure that the design solution is as parsimonious as possible. Sometimes that involves apps. In fact, the majority of our projects within the UW Alacrity Center involve some form of digital technology. But often it also involves redesigning a psychosocial technology and keeping it psychosocial, keeping it as accessible, low cost and low burden as possible. As we all know, for those of us who have developed digital technologies, it can add an entirely different set of constraints, the potential for bottlenecks. And with that, I think I will stop and pass it along to the next presenter. Thank you.
Thank you so much, Dr. Lyon. I already have several questions, and I hope that the audience is starting to develop questions as well. At any point throughout our conversation, if you have something you want to be part of the conversation with our panelists, please go ahead and type it in that Q&A, and we will come back and have a really in-depth and robust conversation. Next is going to be Dr. David Ash. As I shared with you, he's at the University of Pennsylvania. I want to tell you that between 2001 and 2012, Dr. Ash directed the Center for Health Equity Research and Promotion in the Department of Veterans Affairs. He then subsequently also was the executive director of the Leonard Davis Institute of Health Economics at the University of Pennsylvania. His research is in the area of behavioral economics and aims to understand and improve how physicians and patients make medical choices. He's an elected member of the National Academy of Medicine, has received several awards for teaching, mentorship, scholarship, and innovation. And so for those reasons, we are particularly thrilled to have him join us this morning. Dr. Ash? Oh, you're muted, Dr. Ash.
I was saying such great things. So thank you, Rachel. I really feel so honored to join a panel like this with Aaron and Reshma and Vindel. And thanks to all of you for tuning in. So my main role now is directing our Penn Medicine's Innovation Center, and I've been doing that with my colleague Roy Rosen for about 8 years. And I'll make a single observation, which is that since the pandemic, we've gotten more done in the past 9 months than over all of the previous years, even though I'm proud of what we did in those previous years. And I have only a few minutes, so I'm going to give a single example. But first, I want to pose a question about why the pace of innovation and implementation has accelerated so much since the pandemic, and ask what that suggests about moving healthcare innovation and implementation forward in general. And it could be that with the pandemic, the need for innovation is perceived to be greater. I'm actually not sure that the need is greater. I think there's almost an infinite need for change in healthcare, and that was true before the pandemic. But there may be a greater perceived need or perceived demand now. Often it takes a change to create change. There's more of a sense of urgency. There's more focus. There's more a spirit of collaboration. There's less on-site activity, right? Switching to Zoom-like meetings, typically, conducted from home at all hours. There's just more adrenaline right now because of the pandemic. I bring these issues up because we should unpack some of the elements of what we're facing, rather than just making the general statement that the coronavirus pandemic has stimulated innovation. We might look 1 or 2 levels deeper at what some of the elemental factors might be. So I want to give a brief example about a program that we created called COVID Watch, which we use to safely manage patients with COVID at home and illustrate sort of the pace of innovation, at least that I've experienced. So I'm pretty sure the date was around March 11th, when a few of us got together and realized that while all of the attention during the early days of the pandemic was on patients who needed ICUs or needed mechanical ventilators, there was another large problem that wasn't getting much attention, and that was that for every one of those patients needing an ICU, there might be 25 or more who were infected but were in the community. And most of them would do fine, but they might be scared and they might clog up our emergency rooms and phone lines. And of course, some of them would not do fine. And we needed a way to expedite their care if they turned south. So we took a text message based program that we had already developed to keep patients with advanced COPD, emphysema safe, and watched over at home. And we rapidly adapted it to address what we thought was important about COVID triage. Now, the early COVID apps, you probably remember this, were really about asking about symptoms and travel history, and then telling you that you might have COVID and you should call your doctor. And we didn't think that was particularly useful. We thought it was less important to make the diagnosis of COVID-19 and more important to decide if you have COVID-19, do you need to be in the hospital or not? And if so, we didn't want to just tell people, we actually wanted to put them into the hospital. And that's the kind of need that can't be supported by an app alone. In fact, really most clinical needs can't be solved by apps alone. So what we built was half software and half human support. On the human side, we made use of a telemedicine program that we had set up for our employees in the past, and we retasked it with contacting the COVID patients who had escalated because of shortness of breath. So these are infected patients expressing the symptom of dyspnea. So they're potentially in trouble, and they needed immediate contact. So we supplemented the staffing with nurses and doctors. Actually, we used our dermatologists because at this point in the pandemic, they had nothing to do, right? So we'd closed all our dermatology practices. And we wanted to get back to patients immediately. Now, one of the highlights of the story is that from the conception of this program to enrolling our first patient was 12 days. And a few days after that, we had rolled out the program to all 6 hospitals in our system. And now far more of our infected patients at Penn are managed through COVID Watch than through the hospitals and clinics that existed before the pandemic. In fact, 85% of these patients can be managed completely by the automated program. They don't need any human support. Only about 13% of them ever need human clinician support, which is important because the clinicians are, of course, quite busy. And we've made modifications to the program along the way. And I won't go into details about that, but we're at the point where about 2 to 3 nursing FTE can manage a population of 1,000 infected patients 24/7 and keep them safe at home. Now, there are lots of other stories I can tell you that are COVID related, and just as many stories I can tell you that are not COVID related. But the main point is that in all cases, we did this very, very quickly. And actually, our first 8 years of doing this kind of work, it was not so quick at all. And that's the question I want to come back to. Why can we move so much faster during the pandemic when we're busy than not during the pandemic? And is it more perceived need? Is it more urgency? Is it more focus? Is it more adrenaline? And I'm going to conclude my time here with that. I think it's all of these things, but mostly that it was that the usual organizational processes that get in the way of innovation got out of the way during the pandemic. And some of this was because we were united against a common enemy, and there was this new spirit of collaboration. That's all good. But some of the answer, I think, is a bit darker. We set up COVID Watch in less than 2 weeks because I didn't ask anybody's permission, and no one had the time to get in our way, right? The subtext is that all institutions create and harbor elements of obstructionism. And some of this takes the form of people, right? So, the human obstructionists have all sorts of reasons, like retaining power or a defiance against change or low ego strength, that needs external reinforcement. And they can be overt or passive aggressive or use any number of other tricks. But in the end, they are organizational constipators. And these people were just too busy during the early days of the pandemic, and they were too distracted and too much was going on, and they couldn't clog up the system all at once. Now, to be fair, it isn't just people, right? In fact, it's mostly not people. By and large, almost all the people I've worked with are pretty motivated to do good things, but we do have constipated processes. Healthcare organizations put in all sorts of oversight processes that are well-meaning and important, and they're explicitly designed to question change in healthcare, right? That's their explicit purpose. And the reason is that healthcare is high stakes. So we really don't want people going rogue or acting like buckaroos. But a lot of those processes got sidelined or relaxed a little bit during the pandemic, and I think that helped us out. So I'm gonna wrap up here. I think a lot of these processes have come back. The pandemic is worse than ever, but it's not as new anymore. And our usual committees and regulatory processes are regaining their footing. I'm not arguing that we should get rid of these organizational checks and balances. I'd like to get rid of the organizational constipators, like that's a different story. But the organizational checks and balances serve important functions, and we need them, or at least we need something like them. But I do think they go too far in many cases. I do think that the pandemic has taught us that we can get a lot more done and probably retain the safety we want if we relax those processes a bit. You know, those processes are now the tail wagging the dog. We created them, and I think now we need to manage them differently. So I'm eager to hear what others have to say, so I'm going to stop there, but thanks for the time.
Thank you so much, David. As a gastroenterologist and researcher, hearing you use gastroenterology terms in the context of an implementation science innovation plenary with comments from the audience about how to address constipation, I think, you know, part of my work here has been done. So thank you for that, David. But I think you raise really fantastic points, and these are issues that I want us all to get into conversation later. So please, again, go ahead and continue to type those questions in the Q&A because we're going to have a lot of different perspectives, and I want you to not lose those questions you have in mind. Next, we have Dr. Reshma Gupta. And as I told you, she's the Interim Chief of Population Health and Accountable Care within the University of California. In this role, she oversees population health, overuse reduction, care pathways development, and ambulatory quality improvement efforts across the health system. Dr. Gupta's work focuses on health system innovation, policy, implementation design, and education to better define and improve the culture of delivering high quality care at lower costs for patients and health systems. Dr. Gupta?
Well, it's always hard to follow David in panels, so I'll take the hit here now. I really want to thank everyone for this invitation, and I'm very excited to speak with all of you and welcome you all here today for our panel. I really want to start off by making three major key points in my remarks. You know, my current role, as was just described, is really as a health system leader in California that was thrown into the changes of the pandemic. This included the fear, the culture change, that rapid change that David was mentioning. And another part of my role was around strategy across all of the University of California health systems in population health, addressing these changes in real time after the shutdown and currently. So one of the key points I just want to make that has been touched on is around COVID-19 being such a motivator of change around culture. So echoing some of what was just said. You know, and I kind of think back, I'm a history buff, and so I often think back to other examples in the past. And, you know, this is somewhat of a renaissance. So if you think back to the 15th century, when the bubonic plague had hit, Europe really similarly transitioned in that cultural change, both social change and also modernizing. COVID-19 has been a really similar change for us in culture, like we've really never seen. And I think that speed of change and some of what David was mentioning is the systems opening up to new collaborations, new partnerships, a focus on patient community needs, and also a humbling that this was something that we were not used to approaching and needed to move extremely fast, which many medical centers are also not used to doing. From the health system perspective, these kinds of partnerships, including with patients and communities, payers, even internal groups like siloed researchers with health system leaders began to open up as we needed that help. So I think one thing that the pandemic has really taught many of the large health systems is that we are able to change practice rapidly. And what COVID-19 could achieve in just 8 weeks is what years of research, policy initiatives, and emphasizing certain changes such as example being value and reimbursement really could not when it comes to things such as reducing low value services, increasing prioritization around equity. I'll give one example at one of our University of California health systems. So used an application to contact and communicate with patients that were avoiding needed care during the shutdown or during that fear of COVID-19 to more proactively bring them in. We used registries and machine learning technology to identify these patients that may not have been as visible as we needed them to be to receive that care. Similar to David, normally this would take months and months in a normal innovation or research evaluation to get through our system. And our outpatient volume of patients had reduced by nearly 70%. And using this within 2 weeks of that kind of recognition, we were able to get our volume back up to 90% once the shutdown was completed. And so I think this tells us about kind of not only reiterating that point around some of those barriers moving out of the way, but how those collaborations and partnerships, relationships, and infrastructure can really lead to innovation in a rapid pace. The second point I wanted to make was around the factors that really affect that implementation in innovations within health systems and more broadly. So I think especially during our current time period, the local incidence of COVID-19 definitely has ups and downs in terms of what can be done. The financial situation and market changes in the region, having enlightened leadership, which I'll continue talking about a little bit later in our session, really having an efficient organization that can execute those types of changes, and that staff, leadership, the local politics, the culture of reflection and growth during this period. The third point I really want to focus is on where some of these new opportunities are, and I'll brush on a few of them. That when I mentioned having that infrastructure in place, those institutions that had more infrastructure in place to work in new ways, and those relationships were able to instigate and implement innovations that were needed during the COVID-19 shutdown and after more rapidly than other institutions. And in two areas I really want to touch on is one around our financial structures, where there's some enormous opportunities, I think, going forward in healthcare innovation and evaluation. As we commonly know, we live in a system where nearly 95% of healthcare payments have been fee-for-service based. And when health systems have been interviewed about where their priorities are, more than 3/4 of them report that it's around patient volume. And I think what has happened that we learned through this shutdown is that can't continue. That's really affected not only the health system and how it's able to maintain its budget to continue around this work of creating high quality care for patients and access, but it's also in turn really affected our public. The out-of-pocket costs, I think, have been enormous during this period of time as an opportunity for innovation and to address how we as health systems and other partners and payers and those relationships really need to address the crippling effect of that on patients. We know that even simple things are hitting the public and the media around COVID-19 testing, the surprise billing, tests that are in the media coming out over $2,000 a test. And I think these stories cause a lot of fear, and our ability to create those partnerships, that trust, the relationships, the culture are important in this innovation going forward. I think the other component around this is the equity part of it, that there's certain populations that have been hit extremely hard by the economic shutdown, but it goes hand in hand with how we deliver healthcare. If those patients are choosing between, being able to accomplish their primary goals, being able to keep their housing, their ability to pay for medical care may not be that top priority. And there's enormous opportunity when we think with equity in certain communities about that risk of financial harm. So I'll leave you with those notes initially and pass it back to Rachel. So thank you all again.
Thank you, Reshma. You bring up excellent points. Certainly a lot of the issues you raised are factors that have been issues within our own research and clinical practice here in Seattle, and I'm sure others can attest to around the country. So I'm really excited to come back to those points that you raised in our conversation. And finally, we have Dr. Vendel Washington, who in his roles at Verily and at Unduo really focuses on strategies that will enable advanced technology solutions for healthcare transformation. engaging partners in developing tools and platforms for improving health outcomes and reducing costs of care. Prior to joining Verily and Enduo, Dr. Washington served as the Chief Medical Officer and Executive Vice President at Blue Cross Blue Shield of Louisiana, where he oversaw network operations and contracting, medical policy and quality, disease management, and pharmacy benefits. All of these, which, in its current role as well, really highlight several of the issues that we face with this pandemic. So with that, I'll turn my microphone over to Dr. Washington.
Thanks so much, Rachel. I was hoping for the panelists to go on before me. I was learning so much and it was so entertaining. But I'm pleased to share just a few thoughts and then we can get back to the larger panel discussion. So what is the big idea that we're thinking about? What is the innovation that we're focused in on at Verily Health Platforms? And I would say our big idea is really around the central question: can we embrace the complexity that we have as human beings, as opposed to having that be a barrier for us sort of providing care? And so most of what we do from a scientific perspective in medicine, particularly when it comes to discovery and innovation, is to try to really isolate and subsegment, mostly to find out if an outcome is an outcome that is by chance or really related to an intervention. And that is obviously the correct approach in that setting. But the question that we keep asking ourselves is, how do you make that intervention work across a broad population? We know that a lot of the interventions that we try to apply to patients are unequally accepted, unequally executed, and that really just knowing one or two parameters about a patient is not enough to know what is the intervention that is most effective. We may know the medication that's most effective, but given compliance rates, given how people are affected by their social environment, given the effects of monetary barriers for individuals, the real question is, how do I make this person in front of me live their best life? How do I help them live their best life, and how do I help them overcome? There's not a patient who walks in and says or identifies primarily as a disease condition. In medicine, we talk about our diabetics, our hypertensives, but members are much more complex than that. Patients are much more complex than that. So our big idea is, how do you take an individual and treat an individual in the way that they deserve to be treated, find information out about them, find out what they need, find out what helps them live their best life, and take that kind of personalization and bring it to scale across an entire population. We have lots of information that tells us that maybe as little as 10 or 15% of a person's health status is driven by what happens in that 8, 10, 15, 20-minute doctor encounter. The question, though, is, how do we affect the rest of that care? And so we've spent a lot of time on the Verily side thinking about, how can we do this? How do we take information that we have? How do we change this approach? One of the things we were thinking about over this last pandemic is, like, what effect has that had? And I would say it's sort of like, I'm in Louisiana now, it's sort of like a bad ingredient in the gumbo. There is an effect here that needs to be considered, but it is in this complex environment. And so some of the things have become even more hard for many of the members and patients that we care for. That all has to be considered and evaluated, and trying to define what the right outreach is that's likely to be successful. In the vein of outreach, we have developed both digital and virtual solutions, as well as telemedicine solutions to intervene with members. And so we think that's a critical component of how one moves forward in this space. When you find a person that needs care, when you find out what motivates them, when you find out what the personal approach is that's necessary, how do you intervene at a time and place of their convenience? And as many speakers have said before me, I worked in healthcare for many decades, hoping and praying that some of these digital and virtual solutions would gain their legs. And what we found out during the first part, and even through now in the pandemic, is that many of those doors are open. Many of the assumptions we made about individuals was really not true when it came to their adoption of technology or their ability to be cared for in that manner. So we're really focusing in on using those tools appropriately. And the closing comment I'll make is, none of these things were really possible outside of this combination of touch and technology. So we've talked a lot about using technology to scale, to identify, to intervene. But another one of the key factors is marrying that to the right human touch at the right time and place. So from our perspective, it's not just enough to find out who needs what. We also need to have the engine that helps us decide what intervention is most likely to be successful in that encounter. And our best hope is, as we move forward, to continue this marriage and to use technology in this way to increase the touch, as well as we're increasing the precise interventions that are needed for that individual, not the paintbrush solution that we've often used in the past to care for large groups of individuals.
Thank you so much, Vindel. I'm going to welcome back all of our panelists. I'm going to encourage the audience to continue to type those questions into the Q&A. And this session is titled, "What is Innovation for Dissemination and Implementation Research and Practice?" But we never defined innovation, right? Certainly Webster's has its own definition, but I would imagine that across the audience, everyone might define innovation a little bit differently. So I wanted to get the perspectives of a few of our panelists on this term and what it really means when we're talking about research and clinical practice. So Aaron, I'm going to ask you first, how do you define innovation, and how does innovation inform your research in human-centered design and more broadly in implementation science?
Sure. I mean, I guess I'd start by saying I wouldn't say that we go out seeking kind of innovation on purpose. Part of what Vindel was saying really resonated with me surrounding helping people to sort of live the best lives possible that they can. I think we, in our work and sort of the ways we try to leverage human-centered design, we go out seeking solutions that meet the needs and improve the experiences of our identified stakeholders, and try to do that in a way that is as sensitive to their needs and contexts as we possibly can. So I don't know if that's skirting an actual definition of innovation or not, but I'd say that's where we stand.
I think there will definitely be other opportunities to add to that, but I think that's perfect. Thank you so much for sharing that. And there are a few questions around, innovation specifically in human-centered design. So I'll come back to that from the audience. But next, I want to go to David, and I want to ask you, what do you believe was different about this pandemic that helped or hurt innovation and dissemination? You talked a lot about organizational constipators. So, what was different about this particular pandemic that helped to alleviate or relieve some of those constipators in order to allow innovation to happen at such a rapid pace?
Yeah, well, thanks, Rachel. Well, I did talk about the people, but I really do think that although that gets more attention, it really was processes and not the people so much. There were some structural things, right? So there were relaxations on HIPAA. The payers changed what they were willing to pay for, which was a huge change for us. So suddenly telemedicine is reimbursed, at least in part. And it makes you realize how much we were constrained by those regulations or by those processes. It just sort of opens your eyes. You suddenly realize you had sand in your eyes all the time. Now, I think some people realize that we had sand in our eyes before. I'm personally hoping even if we just focus on those two things that I mentioned, HIPAA, very well-intentioned set of policies, within a single regulation, but I think we've all found ourselves tied up in knots with HIPAA. Different payment for telemedicine, honestly, I think that, the cat's out of the bag here. I know why payers do not, I know why payers want to return to a time when they do not have to pay for telemedicine, but let's just say that we've largely settled the issue that telemedicine can be delivered to patients safely. And if it can be delivered to patients safely, it's not obvious to me why we need to have financial constraints on it. I think, I think some very structural things have happened that are separate from the personalities, the obstructionist personalities that all exist in healthcare. I don't think we're ever going to get rid of those, but I'm actually much more optimistic about changing some regulations and some other processes.
And this sort of piggybacks on a question from the audience. When we focus specifically on HIPAA and reimbursements for telehealth, you mentioned, how payers might want to revert to some pre-pandemic behaviors, but do you believe that we can, continue to sustain and, should we continue to sustain these changes even post-pandemic?
Well, I think so, but I mean, let's talk about telemedicine. I mean, why do insurers not want to pay for telemedicine? Well, by and large, insurers are concerned that if you make healthcare too easy, more people will get healthcare. And like, and yeah, I think that's true. And the concern about the way I just framed that is that another way to say that is that insurers rely on making healthcare hard. You know, and it's a kind of rationing by inconvenience. I don't think that's a particularly sustainable position once you sort of frame it that way. But I do understand that if we are going to make healthcare, like most businesses want to make it incredibly easy for their customers to make use of their services. But because we have third parties in the form of insurance, we actually try to put in roadblocks. It's all a substitute for what we wish we had, which was a good measure of which care is appropriate and needed and which care isn't. And because we don't have that, because insurers have not invested in the ability to clearly say this care is needed and this care isn't, instead roadblocks are put in that block all care. I'm being overly simplistic here, but perhaps not too much. We need to innovate on that. And if we could do that, then I think we could free up all sorts of, we could eliminate some of those roadblocks that were put in place and temporarily, at least so far, removed here. So I'm optimistic that we've seen the other side of the roadblock, and now let's try to get there.
Thank you. Reshma, I want to turn to you because what David just mentioned, I think really goes hand in hand with a lot of the comments you made as well from a healthcare system perspective, and sort of, asking you a similar question to Aaron, but in the context of health systems. How do you define innovation, and how can leaders inspire innovation in health systems during challenging times such as what we're experiencing now and even beyond?
Yeah, so when I think about innovation, one of the points I want to make is that there's a differentiation between invention and innovation. So innovation being something where we're really looking at creating new ideas or processes, ultimately to get to a positive outcome through implementation. Versus invention is something where we're coming up with new ideas, but that component around implementation, which is where all the walls come up that we've discussed about those previous barriers, the old way, come in the way. So I really think innovation is taking invention and adding that extra component onto it. And I think that component around implementation is so important when it comes to this realm of what are opportunities around innovation during this period of time, because so much is changing around that infrastructure that we've been talking to, or even with the policies and with the reimbursements for that. And some of that is policies in the relationship with payers, and some of that is our own relationships internally, right? That infrastructure to move technology, to how to curate data, to communicate that between the researchers and those that have data literacy with the health system leadership that sometimes have similar skill sets and sometimes different skill sets. And so when I think about leadership, I use that term Enlightened Leadership, which I think also has many different definitions if you ask all of the panelists. But the way that I think about it is leaders who are open to change, who are practical, but also have kind of a hands-on guiding of how to remove barriers and create organizational change. So not necessarily creating change for change's sake, but having a focus on real purpose and goals. I think having a vision that is practical, but yet can create innovations that are sustainable. And I think that's something that we haven't yet talked about, is with all this innovation that's happening, does leadership have the ability to build and invest so that 5 years from now, we're not back to where we were before? Constipated, I guess we would say. I think the other part is that leaders need to be able to have and build that culture around that mutual respect and that openness and trust, so that we can really gain those relationships. And I'll just mention, just because operationally I think it's so important, data literacy, how to truly leverage data that is meaningful, that is actually going to move the needle, change performance, I think is so vital. And it's also kind of a science, an area of innovation that really needs to move forward much more quickly to be able to create these changes.
Thank you, Reshma. I think that those are really excellent points. In medicine, a lot of times we think in orders of proportions and risk, and oftentimes whether it's patient stakeholders or fellow researchers or even perhaps fellow clinicians, depending on the perspective, We don't often talk about the literacy, like, kind of around those numbers, like numeracy literacy and the data literacy, as you mentioned. So those are really excellent points. Thank you for sharing that. Next, I want to go to Vindel. Vindel, you mentioned, in your introductory remarks, really about, the importance of like outreach and how can you determine what outreach will be successful for whom. And what we know from this pandemic is that those who have been the hardest hit are really those who are in many ways overexposed and underprotected, right? And when we talk about that overexposure, we're really talking about people who have, whether it be pre-existing health conditions or just the inability to practice those measures that we know from a public health perspective could be life-saving. So when I focus in on those with the pre-existing health conditions, these people, because of their particular vulnerability, especially within the event of a health crisis, what are we learning about this pandemic? And what lessons can you share from your work about how we can best support these individuals?
Yeah, thanks for that question, Rachel. If I may, I'll make one quick comment on both David and Reshma's comments around the innovation line. I would say another area that we absolutely need innovation in is in the payment structure. And so many of David's comments, gets back to this, what I would call kind of arms race in medicine, where you have a payer who is responsible for deciding whether or not care is appropriate care and doling out dollars based on how many of those activities have been performed. And having spent a little time in the Obama administration thinking and kind of working on delivery system reform, that structure has arms and tentacles that are sometimes, I think, the effect is sort of underestimated in how they sort of affect and either deliver or relieve the constipation we were talking about in the systems before. So I'd put a little checkbox or maybe a parking lot item about, in addition to the innovation, care delivery, innovation there is important. To the point the question you're framing around those that we care for that are underprotected, have other stressors. Part of what really motivates me as an individual, but also as a key pillar in our company, is recognizing the fact that the burdens that are placed on members in society are not equal in the way that they are affected in one's daily life. And so this idea about personalization says that just because someone has, in our population, for example, a hemoglobin A1C that's 9, the interventions that are needed for person X are different than Y. So sometime in March, we rolled out a series of disease packets on COVID for our diabetic hypertensives who also had that diagnosis. And one of the things that was really clear to us is that if you were an essential worker in that period of time, if you could not isolate at home, a coach can say lots of things to you, your physician can recommend lots of things to you, but if your social circumstance requires you to do something else, to keep food on your table, to keep your roof over your head, and you're not taking those kinds of things into consideration, it's an academic exercise. So one of the things we've been really thinking hard about is there's only so many resources that are available in the health system. One way to think about it is this peanut butter approach where every diabetic gets some type of intervention and it's the same all across that spectrum. The other is to say, with a limited number of resources, treat it almost like a triage situation, where those who may need additional outreach, for us, we started applying more social work, digital support for members that we found that were stressed and in those situations and considerations. We did a lot more back-end research to find resources in the community that might step up and help support people in that environment. We on the healthcare side were not able to, for example, say, we're going to increase this group's median income by some amount. That's just not in our purview. But we certainly have resources that we allot across an entire spectrum of patients. And using some sort of scientific framework to both identify, make these interventions based on what we identify, and then measure their effectiveness, to us is the right way to frame this approach for those who are underprotected and really at stress, particularly at stress during the pandemic.
Thank you. And to my panelists, at any point, you can feel free to jump in. I have lots of questions. The audience has lots of questions. So I'm going to try and go through them. One question that I have for you, Aaron, is, you talked about how, if you're designing for everyone, you're designing for no one, right? And one thing that has emerged as part of this pandemic is how effective telehealth can be. But I think we've also realized how ineffective telehealth can be. And certainly we haven't, we haven't really refined telehealth those who perhaps may not have reliable access to internet, or those who are underage, children. So how can human-centered design help us innovate something like telehealth so it's not a one-size-fits-all?
Thanks. Yeah, I mean, I think it, whether it's telehealth, whether it's any other kind of innovation where some people can kind of have more accessible experiences and more accessible services while other people may be left behind. I think that there are a lot of opportunities. Going back to user identification and sort of identifying who you really believe you can reach and being realistic about that and being data-driven about that. One of the strategies that we frequently use is the development of personas for people who are sort of those archetype users. And that's a sort of well-established, we hardly invented that strategy or technique, but to identify who you really believe you can reach and be realistic about that. As I think we all know, and as has been stated many times throughout this conference, the pandemic that we're in has laid bare all of the inequities that were just below or even well above the surface within our health systems and all of our other social systems in our country and worldwide. And I think we need to be really realistic and thoughtful and target some of the particular individuals who may be less likely to be reached even by traditional telehealth services. Telehealth has been a fantastic way for many people to get additional services, and it can't be the only way people receive services, because inevitably some of the most vulnerable populations, individuals and families are going to be left behind by that. And I think we can all probably get behind that. And I mean, sometimes it's a hybrid of different approaches, but sometimes it's recognizing that old-fashioned, even if somewhat less efficient, and even if additionally constrained, especially in the era of a pandemic, more in-person or face-to-face or distance services may end up being indicated in order to make sure that we are not inadvertently, through our innovation, widening the inequities that are already so prevalent in our nation.
This is a follow-up question for you, Aaron. Many people in the audience would like to know what other frameworks can be successfully paired with human-centered design. So I think for those who are really trying to move this out of an academic sort of approach and into practical context.
Yeah, I mean, I don't think that there are any, to a certain extent, the sky's the limit, right? I think human-centered design types of frameworks are very versatile, and when they really reflect an understanding of context and individuals and an iterative process in order to meet those needs, I would be hard-pressed to find a framework that would be fully incompatible. I mean, I think that any one of, our at last count, is it over 100 implementation science or dissemination and implementation science frameworks could be quite applicable and quite readily paired, because we have this process that can be relevant across different system levels. Of course, if you think about something like the CFR, right, one of the more prominent implementation frameworks that many of us use, there are opportunities to use human-centered design processes at any of the system levels, whether be it outer context or inner context, although it gets a little more amorphous the further out you go to say outer context. But to consider how a lot of these processes can exist within other types of frameworks.
Thank you so much for that, Aaron. I have a question for you, Vendel, from an audience member. And given your experience working with Blue Cross Blue Shield in Louisiana, their question is, private insurance companies are a fascinating stakeholder. Do you have any suggestions for how to collaborate with them on research projects when much of what they do is proprietary?
Yeah, that's an interesting question. I think if you were to approach the industry even now versus 5 or 7 years ago, it is a different industry. The questioner might be aware that the Blue Cross Association is really a kind of a conglomerate of 36 different plans across the country. And so there is what I would call interplay between those quarterly meetings between medical officers and network folks that allow for that kind of discussion about what's going on in plans. And I would say ever since the start of the Affordable Care Act through now, the traditional approach of those plans, I think, for most plans has changed. And you might find that the environment for research and innovation is better than it's been. There's always a little bit of fear of what I would call being disrupted. There's fear that particularly, an integrated delivery network sort of in between the plan and an employer is one of those things that I think that you sometimes need to overcome. But I think framing it in such a way that allows for a win-win to start this discussion, I think opens up that area for collaboration. And I'd certainly be happy to sort of brainstorm on some of those approaches. But the ones I've seen be most effective are ones where you talk about the shared goals, just as David was talking about earlier, the shared goal of trying to deliver high quality care at a low cost and low burden for the individual, and framing the research efforts in those ways, I think ends up with doors being more open than not. I think the pressure for a new system, given the margins, the profitability margins since the ACA, is such that you have a more willing partner for innovation, perhaps, than you would have before the platform was set afire, as it were.
Thank you. Reshma, you talked about how we as a society in general have not really talked much about sustainability, right? And so we've innovated, we've worked rapidly, we've created the programs necessary to sort of get through this pandemic. What are your ideas around how do we sustain some of these innovations from now through and beyond the pandemic?
Yeah, I think there's a few major areas to create that type of infrastructure. And I think, even looking across the University of California health systems and being able to get an inside view on what all the different campuses did and approached it in that rush around the shutdown and now over the last year, the infrastructure is similar, but yet different. And I think especially when we compare with other institutions across the country. And what there's some common lessons learned, I think, that we have had. Institutions that had certain infrastructure were not only able to address the issues faster, but they're set up for something to happen again, right? They have that infrastructure for that sustainability. And I think one component definitely is around the ability to just deliver better care at home and with a clinical hat. I can't emphasize enough how I'm definitely a data person and do machine learning and those types of things locally. But I have to be a clinician on this. There are some patients when it comes to the sustainability where if we don't address the equity issues, we don't address some of those hidden populations, that without just doing the grunt work of asking patients how they're best contacted or talking with the communities and talking with the partners, we're just going to go through the same cycle of talking about innovation for decades and decades and not make the impact. So there's a certain amount of grunt work and relationship building and humbleness that need to happen. But I think once that infrastructure is set, then the ability to go back to it over time and be sustainable will be there. So again, relationships, kind of honing in on that, and then some of that infrastructure of what's right to get technology to those right patients, what risk models identify who are truly at high risk, and having that kind of infrastructure, having relationships with researchers and people with that data literacy. And then as David and Vindel have mentioned, in that environment where payment reform is there, so that we truly can address more proactive, upstream, preventative treatments up front, instead of not having the infrastructure to do that and then reactively trying to create that in a moment of stress, I think is really needed to create that sustainability.
Rachel, can I jump in and
yes,
pile on?
please.
I thought what Reshma said was great, and so I'm going to say it again so that I can get credit for it. So I mean, I really do think that there are all these organizational processes and relationships that have to be built up in some respects sort of unexciting ways to create that platform for innovation within an organization. I think that's how I summarize Reshma's points. In the case at Penn, when we created our innovation center, the first thing, or one of the first things we did, was develop a good relationship with our IRB. And it was sort of like everyone thought we were nuts, because an IRB it just seems like the most, old school way of doing things. I mean, IRBs are very important, but it just seems like so, I don't know how to say this in an uninsulting way, like so boring. And the innovation centers were supposed to be so exciting, but it was one of the best things we did, and creating a process for how are we going to do experimentation within the world of our health system, and that has just paid dividends for us in great ways. And all of the relationships that we built, that we could be a trusted partner within the organization, as Reshma pointed out, I think have been really paid off. And even if I think about what's happened during COVID and all the acceleration, well, I mean, none of it could have happened if we hadn't been building up these relationships for years. And those, some of that was human relationships, some of it was working with the IRB, some of it was just sort of technical infrastructure. But it was all sort of not exciting to talk about. It's exciting to talk about the products. But if you didn't do that groundwork, you weren't going to get anywhere. And I certainly hear other places sort of talking the talk, but they're not willing to put in the effort for the things that Reshma, I think, very articulately said. But now that I've said it, I get the credit and Reshma doesn't.
I'll share.
Does anyone else want to chime in on that? I think really those are excellent points. And, when I look at cities where we think about initial COVID testing as just one example, when I think of cities that were able to get out into the community and do initial community testing very well, there's a program, in Philadelphia, David, led by Dr. Alice Stanford, who's a surgeon who was well connected to that community and was able to do community testing. When I think about, the city of Seattle being able to, do broad testing across multiple kind of sites. When I think about San Francisco and Dr. Kim Rhodes and her relationships across the San Francisco and Bay Area, and being able to partner with, really important communities, Black and Latino, Native American communities, in order to get testing going. And now those testing sites are actually run by people in the community. So certainly those relationships are so important to build on. But I want to also say, because sometimes I think there's this sort of sensation of almost, well, I didn't build the relationships, well, what do I do now? And I want to implore our audience that it's never too late. So you can begin to build those relationships now. No one would have predicted, the great pandemic of 2020, and certainly who knows what's going to happen in the next 5, 10, 20 years. And so you can begin to build those relationships now, because that is the infrastructure that, what our panelists are saying will allow for innovation to happen with whatever the next healthcare need is. So thank you both for sharing that. I am going to take a question from our audience. Let's see. Who have I not picked on recently? Aaron, there are a lot of human-centered design questions, and one that seems to be quite popular is folks wanting to know the major limitations and challenges in applying human-centered design to community-engaged research paradigms.
That's a great question, because I want to make it really clear that, as I may or may not have commented, human-centered design is hardly a panacea, and I mean, as if anything is, and has lots of opportunities for kind of facilitating or being embedded within good quality engagement, which I think is larger than human-centered design, is also sort of fundamental to, but also larger than implementation science. I mean, I often think of things like, I don't know how many people are familiar with Arnstein's classic ladder of citizen participation, dating back, I think, to the late 60s, where the degree of citizen control versus citizens being manipulated by partners. It's not specific to researchers, but individuals who may be coming into given communities. And I mean, I would probably place human-centered design, somewhere between consultation and partnership. There's kind of 8 different levels in this classic model, but it is not fully reaching the level of citizen control. There are still design teams that tend to overrepresent expertise and kind of more traditional expertise than local expertise, who are gathering information from individuals and from communities and trying to make the most empathic design decisions they possibly can. But it's limited. It's not a full community-based participatory research type of model. It falls short of that in some ways for purposes of efficiency, and there may be even greater opportunities to go further in that direction. And of course, this isn't a blanket statement that applies to any kind of human-centered design informed initiative, but in general, this is kind of what I've observed. So I think there is plenty of work to be done, but across the board in all of these domains and all these projects surrounding true, genuine engagement with whatever communities and individuals and teams within healthcare systems, are really going to be the focus of a given project.
Thank you.
Did I answer the question?
I believe you did. I want to switch gears a little bit, and Vindel, I want to ask you, one thing that we're learning more about is really the mental health impact of the pandemic on U.S. citizens and really, people around the world. So how can technology be leveraged for, physical and mental health? Really trying to treat the whole individual and not focusing, solely on the physical manifestations of disease.
Yeah, that's a great point to bring up, the effect of mental and behavioral health on communities. One of the ways that we've framed the question, we've known data about this well before the pandemic, just the sort of pressure that anxiety, depression, dysthymia have on chronic disease. Even when I was at the health plan, it was pretty clear that if you had a combination, a cardiometabolic cluster of conditions and a diagnosis of anxiety or depression, that person was going to have worse outcomes, and that the need for that individual would be greater than if you had any single one of those conditions. So I think the problem was known. During the pandemic, it just became even more clear that solutions were needed. So one of the obvious things is really around the motivational interview and finding out meeting patients where they are from the platforms that we've developed. So that was sort of that also leads to resiliency and digital interventions and telepsychiatry. That's a pretty straightforward line where you say, in the comfort of your home, what can be delivered to you at your time of need. And I think from March to now, we've been steadily increasing the kinds of interventions that we are offering to patients and members. We have not started the work yet, but we also have a theory that you can do good work in substance use disorder and other disorders that we've traditionally said that is just too difficult to approach. But we've been forced to consider other more innovative sort of delivery methodologies as we go further down in the pandemic, and that's been exciting for us. The second component of it is just this idea of resource allocation. So if we can make the system as a whole more efficient, provide some digital care solutions that allow folks to do some self-care, some resiliency training that has value, then our already stretched resources around mental and behavioral health can be held and reserved for other conditions and given to people who have even higher acuity, and it won't be a random distribution of services. They'll be sort of more targeted to those who need them most. And then the last thing I'll mention that's been really clear to us, there's a concept at Alphabet that we certainly have adopted at Verily that's this concept of product inclusivity. So how does a company end up with search capabilities that are touted in Mumbai and other places around the world? One of those is a specific design to say, how do we make sure folks in need have access to the tools? And in the area of mental and behavioral health, what are the barriers? Some of the barriers are psychosocial. Some of the barriers are technological. So this idea of saying, do I have to have a Google Play account? Do I have to go to the Apple Store to get solutions? Does my telemedicine solution require me to download an Epic sort of component or a Cerner component to do this? Or can I get a text message and a few minutes later be engaged in care in a security compliant way? But that's the way that we've been thinking about it, those sort of three pillars. And we think that it's a critical element that if we leave out the mental and behavioral health interventions that you're referencing, Rachel, we think we provide a disservice to our patients and members.
Thank you. And then I'm going to ask one question, and then I'm going to ask everyone to leave us with their take-home messages. So you have a little bit of time to think about your take-home. But this last question I want to ask of Reshma, which the audience members, are asking if this period of innovation, if it really is a true reflection of potential of the healthcare system to innovate, or is it just sort of our short-term ability to make changes? Pretty much asking, you shared how we could be sustainable. The question is really, is this sustainable across healthcare systems?
Yeah, I mean, someone mentioned the word adrenaline before in the panel, and we are all on adrenaline, right? And so to consistently live at that level of adrenaline is not compatible with healthy systems either. So I think the answer would be no in terms of this level and this speed. But I do think I'm an optimist, but that there are great lessons learned that I think can sustain over periods of time for the generation that have lived through this, in terms of that much time. But I think some of that really comes down to two questions that I have been reflecting on as I'm thinking about it as a health system leader. One is, with everything that we've been doing over the last year, do I think in 5 years, what would still be around and what won't? And do I want the things that would be lost, then I need to kind of get to work a little bit more to build that infrastructure? The second question I think folks should ask is doing an environmental scan. If where are things in those relationships around my institution that have moved things forward, where are things that they haven't? And in those, start now to build those relationships, like you were saying, because there's always something that could come down in the future that catches us by surprise. And I think for me, those two guiding questions really help to define that. So to answer your question, would this level of innovation continue? No, but I think, would it be more? Yes. Will it be different? Yes. And as an optimist, I kind of leave it there.
Thank you. All right. Now I'm going to ask you all with 1 minute, what is the take home? What do you want our panelists and the attendees to take away from this conversation around innovation and dissemination implementation, whether it's in practice or in research? And it could be on any of the topics we've discussed. Vendel, can you go first?
Sure. I'm also going to steal one of Reshma's concepts. I think that what we really should be talking about is hardwiring this idea, but I'll go back to my initial sort of framing, which is that we're at a point in time where we cannot afford to be blind to the differences that we have among members of the populations that we care for. And in fact, we should embrace that we're complex and that we have different needs. We need to personalize and do that at scale. I think that's the best way for us to serve the communities that we're charged to serve.
Thank you. Aaron?
Sure. I'd say innovation is about meeting the needs of the people that we're setting out to address and to support and to help kind of live their best lives. And going back to sort of maybe the first point I made, the user is often not like me being those of us who sit in academic settings, enjoy lots of resources. But approaches like human-centered design is not the only paradigm out there, that promote understanding and empathy for well-specified users and their context, have the opportunity to improve equity in particular when properly applied as a function of empathy and as a function of deliberately elevating the needs of those individuals.
Thank you. David?
Sure. Well, I had a change of heart, I think, during the pandemic, in that I'm usually a pessimist, and now I'm an optimist in some weird way. And I used to think that we had an innovation center at Penn at a time when we were doing well financially, and that as soon as we hit a dark time financially, like during the pandemic, they would get rid of all of us because you don't want to fire your transplant surgeons, but your innovation center seems sort of discretionary. And now I don't think that at all. And now I think that around the organization, people are saying, oh man, now I realize why we needed an innovation center all along. And I have this renewed sense of purpose and sense of value. And I think we can all share in that you can't sort of outsource innovation. You have to retain it inside. You have to have some internal capability to do that, or you're incredibly vulnerable. It's not a luxury. Like every organization needs its own R&D, and innovation is part of that. And I'm thrilled to be part of that at Penn. And I think it's sort of I needed this pandemic. No one needed this pandemic, but this pandemic helped me see something that I might not have seen otherwise.
Thank you, David. And Reshma.
Yeah, I'm going to echo David on the fact that the culture change that has happened locally by just our system being humbled and vulnerable has been a blessing. And I mean, a lot of this innovation kind of being able to go forward has been that. And so I would, some parting messages would be take a hold of it and start thinking in ways that make programs sustainable, but don't step out, step in, lean into this time period. And the second is actually a comment that one of the audience members had written, which is how powerful people are. Don't forget how powerful people are, because there are so many people, I think, out there that are wanting to help, but they don't know how, and they're not being asked. And so the partnerships they are there from people that we don't expect. And so there are lots of opportunities that we just need vision around. And we'll be able to kind of, I always say this, instead of keep hitting your head against the wall, find a way to dig around the wall, go under the wall, climb over the wall, but just get around the wall. There's a way.
Thank you so much. It's truly been a pleasure to be in conversation with you all today. I hope our audience enjoyed this time as much as I did. Thank you so much, and I hope you enjoy the rest of the conference.